All right. So my name is Petar Bajic. I'm the director of the Center for Men's Health at the Cleveland Clinic in Cleveland, Ohio. And I'm going to be talking to you today about the contemporary management of erectile dysfunction. We're going to spend some time going through some pertinent anatomy. We're going to talk about risk factors for erectile dysfunction, or ED. We're going to talk about how we work these patients up, how to determine and when to determine if somebody might be testosterone deficient, and how to treat that when appropriate, and really how to have that important discussion with the patient on what their options are, and then engage in a shared decision-making approach. So just a quick little bit of anatomy. These are two images of the penis in cross-section, and essentially the penis on the left is flaccid and the penis, or soft, and the penis on the right is erect. So whether or not a man has an erection is determined by two small arteries at the core of the penis called the cavernous arteries. I'm not sure if you can see my little pointer here. Is it this? Yeah, laser pointer. All right, maybe you can see there now. So those two arteries engorge or allow blood to flow into the penis when a man becomes aroused and stimulated. That blood then pools in these spaces around those arteries, and then the pressure inside of this space increases until the pressure is so great that these little blue veins here, which normally let blood flow out of the penis, actually get clamped off. So the penis becomes pressurized, the blood can no longer flow out, and the erection is then full and maintained. So there's a couple different ways that ED can happen. The first is if there's not enough blood flow in. So simply back to this picture, if there's not enough blood flowing into these arteries because of hardening and narrowing of those arteries due to cardiovascular disease, that might be a reason to not be able to get an erection. So we call that arterial insufficiency, and that's the most common cause of ED. There's another problem called venous leak, which essentially the blood flows in just fine, but these veins never really completely close off when a man is trying to get an erection. So blood comes in and it leaks right out, and they never get or maintain that full erection. The third type of ED is called psychogenic, which means based on something going on in their head. Doesn't mean it's in their head, but what's in their head is their brain, which has overall control over the whole body. So if a man is experiencing performance anxiety, he can actually initiate what we call the fight or flight response, similar to what he might experience if he's, scared or has an adrenaline rush. What happens in that scenario is that there's actually a decreased responsiveness of those arteries to arousal and stimulation. So what that means is that if a man is anxious enough, he can shut off blood flow to his penis and actually cause ED. So what are the most common risk factors for ED? Those cardiovascular risk factors: high blood pressure, high cholesterol, diabetes, and smoking. These account for the majority of cases of ED. So we refer to the penis as the divining rod of vascular health. So if a man is starting to experience ED, it may be the canary in the coal mine, so to speak. It's something more serious, like a heart attack, could be around 5 or more years down the road. This all happens as a result of something called endothelial dysfunction and, as you've likely heard of, atherosclerosis, so hardening and narrowing of the arteries. Notice that age and obesity are not direct risk factors for ED, but many of these medical conditions come with age and when men gain weight. Other risk factors: depression or a side effect of medications. That's pretty common. Alcohol use, trauma or pelvic surgery like prostate removal, neurological disease. I put obesity here mainly because some men may not have diagnosed medical issues, but may be obese and just have not established with primary care. So we definitely see some men, who probably have blood flow related ED that maybe don't have those things in their past medical history. Radiation, Peyronie's disease is a scarring condition of the penis that can cause a penile curvature. And then the last one here, hypogonadism, also known as testosterone deficiency or other hormone issues, only make up about 3% of cases of ED. It's a very common misconception that ED is caused primarily by low testosterone. That is not true. Low testosterone might contribute, but it's usually not the primary cause. Now, for men who are much younger, who develop ED and don't have cardiovascular disease in their past, these types of hormone problems become a little bit more likely. So how do we evaluate these patients? Well, sometimes in the urology office, we use validated questionnaires, but those may not necessarily be practical for everyday use. But some even primary care practices like to use simplified versions of these questionnaires just as a way to initiate the conversation and get the guy starting to think about his ED issue and maybe bringing it up to you. But in this day and age, we want to be as inclusive as possible. And some of these questionnaires do tend to focus on vaginal penetration, which may not necessarily be something that all men out there are interested in or partake in. There's other types of scales that I won't get into too much detail about. But one of the really important things that we want to evaluate for, in addition to erectile dysfunction, is whether a man might have premature ejaculation. That means after initiating sexual activity, he ejaculates too quickly. This is really important because what many men don't know is that after ejaculation, it's normal to lose the erection. And the older a man is, the more time it takes before he can have another erection after ejaculation. So a simple question you can ask a man when he reports that he loses his erection too soon is, do you lose your erection because of climax, or do you lose it before even reaching climax? Because the two issues are a little bit different and require a little bit of a different treatment. Other questions that can be valuable is asking a man if he experiences morning erections, which sometimes can point to more of either a situational problem where maybe he has performance anxiety, or sometimes may actually point towards the ED being a side effect of certain medications, which we'll get into a little bit later. But if a man wakes up with a really strong erection and then after taking his blood pressure pills is not able to have an erection for the rest of the day, those blood pressure pills might be contributing to the problem, and there might be some alternatives that might be less likely to cause those issues. We also want to get an idea if they might have a new penile deformity, like a curvature that they did not have before, because this condition I mentioned called Peyronie's disease can sometimes increase the risk of ED. It's always good to get an idea of their overall cardiovascular health. Do you get out of breath walking upstairs or down the block is a simple question that you can ask. You want to make sure you review their medication list and any supplements that they might be taking. When it comes to antihypertensives, it's pretty common that they might contribute to ED, believe it or not. Even though hypertension is probably the most common cause of ED, certain medications can actually make the ED worse. Beta blockers are notoriously the worst out of all the different blood pressure pills. So when feasible, we usually work with the primary care doctor or a cardiologist to consider alternative medications if feasible. So if they're on a beta blocker or even a diuretic, for example, Lasix is one, or hydrochlorothiazide that do contribute to ED as well, we might consider working with the primary care team to change them to a calcium channel blocker, which are usually the best blood pressure pills for not contributing to the ED issue, or even an ACE inhibitor or angiotensin receptor blocker. Those are all pretty good and don't usually contribute to the ED issue. For antidepressants, SSRIs are notoriously the worst, okay? Bupropion, when appropriate, is a really good alternative that's much less likely to contribute to ED. For anxiety, it's a little bit more difficult. There's not a great option, but probably Buspar, when appropriate, is better than SSRIs. Even BPH medications, finasteride and dutasteride, which are called 5-alpha reductase inhibitors, commonly contribute to ED, low libido, and often even cause breast enlargement and tenderness. So some alternatives that are less likely to impact sexual function, actually daily tadalafil or Cialis is probably the best one because that one actually helps erections. Alpha blockers like Flomax are also pretty good, but those can cause some issues with ejaculation. Actually, specifically, it's dry ejaculation, which some men are bothered by. And then anticonvulsants and antipsychotics can also sometimes contribute. Always get a good medical and surgical history, including any history of cancers, radiation, or pelvic surgery. Get an idea of substance use, particularly tobacco, drugs, and alcohol. Actually, cannabis and also chronic opioid use can lower testosterone levels, so that's an important part of the history. It's also a good idea to ask a patient a little bit more about their sexual activity. And what I've come to find is that these two questions in the green are a very inclusive, non-judgmental way of asking somebody who they are having sex with. So who do you have sex with and what kind of sex do you have? And this is a way you can get a better understanding of if the guy is, sexually active with a female partner, male partner, or maybe not with a partner at all. And people can be sexually active even without a partner. On physical exam, we pay attention to their overall appearance and affect. We do sometimes pay attention to secondary sexual characteristics like gynecomastia and hair loss, which may have some implications for some of the hormonal causes. And on a genital exam, we check the testicles first to make sure there's no masses, to make sure they don't have testicular cancer. But sometimes we can also tell that the testicles are very small and very soft. And that might point towards a testosterone deficiency because most of the testosterone is produced in the testicles. Varicoceles are dilated or varicose veins above the testicles, which sometimes feel almost like a bag of worms. Sometimes those might contribute as well. And they can be also associated with scrotal pain and infertility in some men. Usually they don't cause any symptoms, and if they're not symptomatic, they're really not anything we would do anything about. If you think a man might have Peyronie's disease, putting the penis on stretch and then feeling along the length of the penis from the sides might allow you to feel a nodule, which we call a plaque. That's the actual scar tissue that causes a curvature in the penis. And then depending on their age and risk factors, we do think it's a good idea for many men to check a digital rectal exam, particularly if they're at high risk for developing prostate cancer. Although PSA screening, we still recommend as kind of the standard way of screening men who are at risk of prostate cancer, which in general is men age 50 to 70. And for men with a strong family history, we recommend PSA screening starting at age 40. A digital rectal exam can also help you determine whether there's any nodules in the prostate. Although that doesn't have anything to do with erectile dysfunction, men who come to see you for ED are typically in this age group where they are at risk of prostate cancer. Let's talk a little bit about testosterone deficiency. So importantly, there's a large association between testosterone deficiency and sleep apnea. So the thing is that the symptoms of low testosterone and the symptoms of sleep apnea are virtually the same. So a lot of guys come in thinking they have a testosterone deficiency, but they might actually have undiagnosed sleep apnea. So I always recommend if you're thinking testosterone deficiency, make sure you screen the patients for sleep apnea. And that involves the stop bang criteria, which you probably have heard of at some point, plus or minus a home sleep apnea test. So we'll get back to why this is important in a minute. But essentially, men who have undiagnosed sleep apnea who are put on testosterone replacement therapy, it actually causes sleep apnea to get worse. And that might predispose them to having complications as a result of testosterone replacement and might actually prevent them from feeling better and might actually make them feel worse. Some of the symptoms of testosterone deficiency are fatigue, irritability, low sex drive, ED, lack of motivation, depression, difficulty losing weight, and loss of lean muscle mass. Usually if a man is truly testosterone deficient, he tends to have multiple of these rather than just the ED. If you think a man might have testosterone deficiency, it's important to check a total testosterone level in the morning when the testosterone level is at its highest. A lot of guys, most guys, have a low testosterone in the afternoon. So I commonly get referrals for men who have had an afternoon testosterone level that was slightly low. And then when we repeat it in the morning like we're supposed to, it's actually normal. So we define an abnormal or low testosterone level as less than 300 on a morning blood test, and they have to have signs and symptoms. We don't treat testosterone deficiency unless there is some symptom. We also check PSA levels, as I mentioned, depending on age and family history. If a patient has not had cardiovascular screening and they're coming in for ED, particularly if they're over 30 or 40, you really want to think about making sure they have lipids, blood pressure, and all that stuff, because usually this is a consequence of underlying cardiovascular disease. Think about checking a TSH because sometimes thyroid issues can also contribute to ED. And then if they're diabetic, make sure they're well controlled, because poorly controlled diabetes is probably the worst thing for erections. I always tell my diabetic patients that with diabetes, no matter what you do, the erections are just going to get worse. But the speed at which they decline is dictated by the blood sugar control. So if it's poorly controlled, they're going to have a rapid, irreversible decline. If they keep it controlled, they will still decline slowly over time, but it'll be a much slower process. Sometimes in my specialty, which is sexual medicine, we do a penile Doppler ultrasound. It's optional. It's not something we always recommend, but in certain situations when there's not a clear cause of the ED in somebody who's vascularly healthy, we may do this test to diagnose whether there's a blood flow problem with reduced blood flowing in, or perhaps a valve issue where the blood is leaking out. The reality is that no matter what the cause of the ED is, the treatments are pretty much the same, as we'll get into shortly, but sometimes this can help with counseling. Men who have no risk factors, who are young and we think they might be psychogenic, sometimes this can be a good way to prove to them that there's actually no structural problem, and that can be part of their way of getting past the mental aspect of this. We also use this in men with Peyronie's disease because it can help us select appropriate treatments, but that's beyond the scope of the talk today. Let's get into treatment options. Historically, in urology, we've used a stepwise treatment paradigm. And what that means is we would always start with lifestyle modifications, like, maintaining a healthy lifestyle and diet to reduce those cardiovascular risk factors, and increasing cardiovascular exercise. Then if that didn't work, we would try oral medications. Then if that didn't work, we would move on to kind of second line treatments, which are things like penile injections, urethral suppositories, vacuum erection devices, and then if that didn't work, we would consider something called a penile prosthesis. More recently, our guidelines in urology changed in 2018 based on the most contemporary literature, and we actually suggest that basically patients, particularly those who fail oral medications, really be informed of all the available treatment options for ED, so they know what's out there. Because some men who are just offered Viagra only, if it doesn't work, they may just give up and never bring it up to another doctor again. So when they know that there are other options for men where the Viagra or Cialis doesn't work, that empowers them to continue the conversation and continue seeing either their primary or a urologist until they find something that works for them. So this is how we approach this. And you don't need to be a master of all of these, but I think just knowing that these options are out there will allow you to have more informed discussions with your patients. When we talk about behavioral changes, these usually don't fix ED, but sometimes might allow for a little bit of improvement. The most important one is increasing physical activity. 40 minutes of cardio, vigorous cardio, 4 times a week. That's exercise where they're getting out of breath. 160 minutes of exercise a week is a lot. Not many of our patients do that, but it's something that they can do if they're motivated. Absolutely critical that they stop smoking. That won't reverse ED, but it will prevent things from getting worse, which is important. And then alcohol is an interesting one, because a drink or two might make them more likely to initiate sexual activity. But if they have too many, it's going to shut everything down through central nervous system inhibition. Sex therapy is always something that we recommend because there are a lot of different benefits to it. It's different than regular psychotherapy. It's specifically geared towards intimacy and their sexual relationship with their partner, and barriers to them, having the maximally enjoyable possible experience with intimacy. It can also help to promote treatment adherence, improve communication, reduce performance anxiety, integrate many of these treatments. It can be useful for both organic, or when we say organic ED, we mean ED that has some sort of medical cause, and also for psychogenic ED. Overall, it increases satisfaction both for patients and their partners. As far as medical treatments go, there are several PDE5 inhibitors. Sildenafil is another name for Viagra. Tadalafil is Cialis. Vardenafil is Levitra. And Avanafil, which is the newest one, is Stendra. Really, in my practice and in the practices of most of us who do a lot of sexual medicine, Viagra and Cialis make up 99.9% of the oral medication prescriptions that we write for ED because they are generic. And you can get 90 tablets of full-strength Viagra or Cialis through Mark Cuban's new Cost Plus Drugs mail-order pharmacy for about 10 bucks. So many men, they look online and they find these direct-to-consumer advertising platforms that charge hundreds of dollars for these drugs, and they may not know that with a prescription from you, they can take it to one of these pharmacies or even use a GoodRx card to get a really cheap, high-quantity prescription of these, and the generics are just as good as the name brand. Levitra and Stendra are also good. They're just more expensive, so we rarely prescribe them. Pretty much all of these pills are equally effective. It's important, though, for men to know that you do have to have stimulation for these pills to work. Some guys think they're just going to go take one and wait around and that they're going to get an erection. It doesn't work like that. It just makes it easier for more blood to flow into the penis. There are some differences between the different medications as far as how quickly they kick in, how long they last, and whether or not they're affected by food intake. My favorite is the tadalafil or Cialis. One benefit is that it is not affected by food intake, whereas Viagra is. If you take Viagra after a big meal, which many men take it after dinner, it may not work as well. Importantly, the Cialis can be prescribed in two different ways. When we prescribe it for sexual activity, it's usually in a full strength 20 milligrams or sometimes 10 milligrams to be taken 1 to 2 hours prior to sexual activity. So it takes a full 1 to 2 hours to kick in, but it lasts up to 36 hours. They're going to get most of their benefit in those first couple hours after they take it, but they might even notice the next day they might have an easier time getting an erection. Cialis can also be prescribed in a low dose, 5 milligrams daily, which is primarily meant to be a treatment for urinary symptoms due to prostate enlargement. But some men with mild ED prefer to take the low dose daily because it allows them to have a little more spontaneous erections and not have to worry about timing the pill so much. For men who have testosterone deficiency and also ED, we know that pills work better when they are combined with testosterone replacement therapy. In other words, if you have a patient with untreated testosterone deficiency, the pills like Viagra and Cialis are probably not going to work. They need to have a normal testosterone level or within kind of the normal range to respond to these therapies. So sometimes we see guys who were diagnosed with testosterone deficiency many years ago. They tried testosterone for a little while and didn't notice an improvement, and maybe they didn't try the pills properly at that time. And now they want to try a prescription for Viagra or Cialis, but until we get their testosterone to where it's supposed to be, they're probably not going to respond to that. So that's something that's important to know. If the testosterone level is low and they have symptoms as a result of that, and they don't have sleep apnea, or if the sleep apnea is treated, we would consider treating that testosterone deficiency to try to help their erections. Usually in my practice, first-line therapy for testosterone deficiency is either an intramuscular injection we teach them to give themselves in the thigh once a week. We use 100 milligrams of testosterone cypionate weekly. Oftentimes I see 200 milligrams every 2 weeks. That's also fine, but with that they tend to get a little bit higher peaks a day or two after the injection, and then they sometimes will drop off a little too soon, so they might feel like they're crawling the last couple days before their injections. By doing a lower dose more frequently, you don't get those peaks as much, and we think the really high peaks in the blood levels of testosterone after a very large injection are probably what drives some of the complications like thickening of the blood or raising of the hematocrit. Alternatives to that are topical testosterone. I usually use generic androgel, 2 pumps daily to start. And then there's also a procedure we do in the office called Testapel, or testosterone pellet implantation, which they don't have to do anything at home. They just come in every 3 to 4 months. It's kind of like a depot little pellet underneath the skin. So those are well tolerated. The reason those are first line is because usually we are able to get those covered by insurance without any, other criteria. If they aren't good candidates for those, or if they've tried and failed those, we move on to second line treatments, which are a little harder to get covered by insurance, but usually if they've tried the other stuff, we can get them covered. There's a subcutaneous auto injector, which is better for people that don't like the big needles from the IM injection. There's actually oral testosterone and intranasal testosterone. How do we monitor blood work when somebody's on testosterone replacement? If they're on injections, I personally like to check end cycle levels. So I usually have them get blood drawn the day before their shot. I want to make sure that at the end of their week, they're still in that normal range above 300. It's also okay to get a mid-cycle level as well. If they're on topical T, you really want to have them put the gel on and then wait 3 to 4 hours and then get blood drawn. If they get blood drawn before they put the gel on, it's probably mostly out of their system because it only lasts about 24 hours. And then with pellets, we usually check blood work at 2 weeks and then at 3 months. It's important to monitor hematocrit and PSA level in men who are on testosterone replacement. Testosterone replacement can cause the hematocrit to go up, and if it gets too high, that could be dangerous. The testosterone also can influence the PSA level. In general, we do not believe that testosterone replacement causes prostate cancer, but in any man who develops an elevated PSA on testosterone, we need to make sure we're monitoring that closely and that they're counseled appropriately by a urologist regarding the risks of prostate cancer. Testosterone can make sleep apnea and BPH worse, so that's something to be aware of. And men who have a history of prostate cancer, particularly those who have had prostate cancer that's been treated and cured, are eligible for testosterone replacement therapy when appropriate, but really those patients should have their testosterone managed by a urologist experienced with prostate cancer and testosterone. So that's something that we do a lot of at our Men's Health Center. Men who have undergone prostate removal for cancer often develop ED. We call that a prostatectomy. It's one of the most common side effects of prostate removal and can also happen as a result of other pelvic surgeries like colon removal, etc. However, these men are less likely to respond to oral medications like Viagra and Cialis because the cause of their ED is different. It's not so much a blood flow problem. It's more related to nerve injury that occurred during the prostate removal because the nerves that are important for erections run along the sides of the prostate. Pills like Viagra and Cialis rely on those nerves being intact. So if they've been damaged, the pills may not work, and they should probably see somebody, who can talk to them about the alternative options. There is some thought that maybe giving men pills like Viagra and Cialis right after prostate removal might be beneficial, but really we don't have any solid evidence to say that that helps with their erection recovery. By the way, erection recovery after prostate removal can take between 12 and 18 months. So what are some of the alternatives to pills for men who either don't like them, are ineligible for pills, or if the pills don't work? One option is called intraurethral suppositories. It's essentially a pill that goes into the tip of the penis, which is not exactly something a lot of guys think would be fun to do, but for some men it works. The biggest problem with it is expensive and not covered by insurance, so I almost never prescribe this. It can also cause some pain and burning with urination. Intracavernosal injection therapy is pretty much the strongest drug that we have for ED. There are a lot of different pills that can be, a lot of different drugs that can be mixed together by a compounding pharmacy to create the injectable drug. But this is essentially a medicine directly injected into the penis that acts locally as a vasodilator to increase blood flow to the penis. With this treatment, men can get an erection even if they're not aroused. So they give themselves the shot, and after 10 minutes, it's going to kick in. However, the big risk here is if they give themselves too much, or if they get creative and try mixing the injections with oral medications like Viagra and Cialis, they might experience priapism, which is a prolonged, painful erection due to ischemia or lack of blood flow in the penis. When you hear on the commercial, they talk about if you have an erection lasting longer than 4 hours, go to the ER. That's what priapism is, and it can cause permanent and irreversible damage to the penis. So we're always very careful with how we instruct men to do this, and we always test the first dose in the office to make sure they don't develop this. Unfortunately, although many men are satisfied with this treatment, there's a high dropout rate. Many men quit it within the first year or two. So any man who decides this is not for them really needs to have a discussion with the urologist about what else is out there. So we make sure that they know what alternatives they have. So it's important they get that follow-up. Men who have Peyronie's disease, which is that scar tissue condition of the penis that causes curvature, should never get penile injection therapy because those injections may lead to further scar tissue formation, which might cause a worsening penile deformity. There are some mechanical devices out there that can be used to help with ED. One is called a vacuum erection device, which is a plastic tube that goes on the penis. There's a button on it that creates a vacuum inside that causes the penis to fill with blood. Once it's full, they slip a rubber band down in the base of the penis to hold the blood in. It's kind of cumbersome. It's not the most natural erection. It can cause some bruising and discomfort. It only engorges the external part of the penis, although half of the penis is actually inside of the body, so it's kind of a floppy, unnatural erection. Some guys go for it. Some guys try it along with the pills, but in general, satisfaction is quite low. There's also a device that you should be aware of that's called a penile traction therapy. It's not meant to fix ED, but in men who have some conditions like Peyronie's disease that can develop penile shortening, it can help with some of their length concerns, and there has been some suggestion in some studies that it might help their erectile function a little bit. Moving on to restorative therapies, these are the ones you're most likely to hear about on billboards and on TV or radio. The biggest one is called wave therapy, and we'll talk a little bit about a couple different types of those. There's also stem cell therapy and platelet-rich plasma, or PRP. There are two different kinds of wave therapies. The most commonly advertised one is called radial wave therapy. There's a company called Gainswave that partners with small practices and provides equipment and marketing for these types of devices. These are essentially a vibrating device that creates regular sound waves and causes some, vibration in the skin that is thought to improve blood flow. However, the most recent studies that are available on this type of technology really show that it does not cause any meaningful improvement in erectile dysfunction. Unfortunately, many clinics continue to charge men between $6,000 and $8,000 for this type of treatment, and really with no evidence to support it. Sometimes those clinics use ultrasound to basically show some arteries in the penis, and what they do is they find some small arteries and say, look how small your arteries are. Then they do the radial wave, and at the end they do another ultrasound, but they find a bigger artery closer to the body, and they say, look how much bigger your arteries are. So it's a little bit of placebo effect probably happening there. This is something that is commonly confused with a different type of treatment called focused low intensity shockwave therapy. Shockwave therapy is a treatment that has been used to crack kidney stones for decades, okay, in a non-invasive fashion. But in a lower energy setting has been applied and FDA approved for the treatment of conditions like plantar fasciitis, chronic non-healing wounds, and more recently has been applied to several different applications, including erectile dysfunction. It is not FDA approved for the treatment of ED, which means that it has not gone through the extensive testing for safety and effectiveness that is required to gain that stamp of FDA approval. However, there are a number of studies from all around the world, randomized controlled trials that support the use of this technology for the treatment of blood flow related ED. Usually men who have mild to moderate ED who get at least a partial response to pills like oral medications have been proven to have some benefit for those men. The way that it works is it takes sound waves and focuses them on a single point that then leads to some microscopic trauma to the penis, which stimulates a healing response or increase in vascularization. Basically, new blood supply forms. So this is something that we do offer at Cleveland Clinic at several of our locations. And unfortunately, because it's not FDA approved, it is not covered by insurance. So we have two different ways that men can get this treatment. One option is they can pay out of pocket. It's about $1,800 for the full 6 treatments, which is understandably a lot for many men. But we also have a number of clinical trials because this technology has shown promise. We're continuing to do a lot of research on how it can best be applied. So men who participate in our clinical trials can get this treatment free. So just a graphic description of how these treatments are different. On the right, we have radial wave therapy, which if the little generator is there in the red, it basically just spreads out these sound waves in all directions, whereas focused shock wave focuses that energy on a single point. And all of that energy coming down on this single point leads to a lot greater energy delivery and also deeper penetration into the tissue. So that's the difference. What is platelet-rich plasma? So this is essentially when you take blood out of somebody, you spin it down in a centrifuge to concentrate it, and then you take part of that blood that's concentrated with all the different things that are in blood, like growth factors, etc., and inject it back into somewhere in their body. Other names for this are the P shot or the Priapus shot when it's specifically used for ED. And the thought is that this increases recruitment of stem cells, reduces inflammation, increases blood flow or blood supply to the area. There have not been a lot of different studies performed on this, but there was a very recent, very high quality study performed by a group out of Miami that proved that this treatment does not improve erectile dysfunction. And that was actually a sham control study where they compared it to an injection where they did not give anything, and there was no difference. So a fake injection was equivalent to PRP. According to the American Urological Association, this is an experimental treatment and should not be administered except as part of a clinical trial. Many practices that offer this charge between $1,500 and $2,200 per treatment for this. For something that doesn't work, I think that is inappropriate, and really this should only be performed as part of research. I actually had a slide on stem cell therapy as well, but I think it just recently removed it from this talk. But basically almost the same thing as the PRP. Sorry, I have to pop up on my screen. Okay, so almost the same problems as PRP. There's really no evidence from human trials to show that it works. So it's considered an experimental treatment, but we don't even have any large studies to prove that it works or doesn't work. So for right now, it should really only be performed as part of research. So moving on to surgical treatment, penile prosthesis implantation is kind of considered by urologists as the gold standard treatment for men who fail oral medications. Sorry, my Siri keeps coming up here. Okay, I think we're good now. So penile prosthesis implantation is considered the gold standard treatment for medication refractory erectile dysfunction. There are two different types of devices out there. There's a semi-rigid, which is essentially an implantable device that's kind of like a bendable rod that men can either bend it up when they want to have sex or bend it down when they want to conceal it. Or the alternative device, which is actually the one that's most commonly performed, probably over 99% of penile prostheses or penile implants in the country are called three-piece inflatable devices. This is actually the oldest treatment that we have for ED, but interestingly, it's the one with the highest satisfaction, and it's really the only one that's routinely covered by insurance, including Medicare, Medicaid, and commercial insurance. What it is it's a completely internal device that's controlled by squeezing a hidden pump between the testicles. So it's almost like a third ball. When they want to get an erection, they squeeze that pump over and over again until the penis gets completely hard. And it does so by filling two balloons inside the penile shaft with salt water. It almost fills the penis like an inner tube fills a bicycle tire until it's completely hard. It does not impact sensation, urination, or orgasm. All of those things are still the same, but the man can have an erection on demand when he wants it, and he can stay hard as long as he wants. When he's done with having the erection, or when he just wants to have it be soft again, he feels above that pump for a small release valve that he squeezes. When he squeezes that, the penis becomes soft again, and it pushes that fluid out of the penis and into a small storage balloon that's hidden behind the abdominal wall muscles until next time he wants to use it. From the outside, nobody would ever be able to tell that a man had this, but this is essentially a 30-minute to 1 hour outpatient procedure. And it can be placed through a couple different approaches. There's an approach, and this, by the way, this is a procedure done under anesthesia. The image on the left depicts the peniscrotal approach, which is essentially a small opening on the front of the scrotum, which looks big here, but that's because the scrotum is stretchy. It heals with almost no scar that's visible. Alternatively, the infrapubic on the right there, or minimally invasive approach, is done through a small, about 1-inch opening above the penis. So either one of these can be used to insert a penile implant. If we look at treatment satisfaction of the various treatment options that are available for ED, the PDE5 inhibitors have a treatment success rate of about 50%. Vacuum erection devices are as low as 10%. Penile injections up to 41%. But the inflatable penile prosthesis, across all studies published within the last few decades, routinely has treatment satisfaction upwards of 85 to 98%. Like I said, it does not change their sensation, voiding, or orgasm. It's just a reliable way of getting an erection. All procedures have some risks, and the risks of this type of procedure are pretty comparable to hip replacement or knee replacement. The primary risk of any implantable device is the risk of infection, which for men who are not diabetic is only about 2%. For diabetic men, it's probably about 5%. It's exceedingly rare for the device to extrude or wear its way out of the body. These devices, on average, last about 20 years, and 85% of them last for at least 10 years. If it ever breaks, the only thing that happens is they can't get hard, but it can be removed and replaced for a new one. Some men do complain about a loss of penile size, and they think that that's due to the implant, but in reality, that's due to ED. I always tell my men that if you don't use it, you lose it. And what that means is if you don't get an erection for 10 years, when you finally get that erection after an implant, it's not going to be exactly like the penis you had 20 years ago. And that can be, unfortunately, for some men, a tough pill to swallow, but we spend a lot of time counseling them to make sure that they know that going into it, that this is a function restoring procedure. It's not a cosmetic procedure, and that's why it's covered by insurance. So in my opinion, what are the indications for surgical treatment? Really any man who desires the most rapid and reliable erections who cannot achieve that with pills. Anybody who's not intolerant to or not a candidate for medications or simpler treatments, and certainly men who have failed less invasive approaches. And it's important that when we present men with these options, we engage in a shared decision-making framework where we take into consideration their values, goals, and expectations, and offer them whichever treatment seems to fit right for them. We don't force them to stick needles into their penis before consideration of a penile implant like we used to 20 or 30 years ago. So what are some key takeaways? Erectile function relies on good blood flow into the penis and normal trapping of blood. Erectile dysfunction is most commonly caused by cardiovascular risk factors like blood pressure, cholesterol, diabetes, and smoking. You need to think about testosterone deficiency and do an assessment in men who have ED, particularly when they have some of the other signs of testosterone deficiency as well. And we should use a shared decision-making approach to make sure men know what treatment options are out there and then decide along with them what the best option is for them. So just a couple slides here about us at Cleveland Clinic. The Glickman Urological and Kidney Institute has been rated in the top 2 in the country many years in a row. This year was rated number 2. Our men's health group is comprised of 6 physicians and 6 APPs who span the entire Cleveland Clinic system through Northeast Ohio, including West Side, main campus, East Side, and also the Akron-Canton area. So all of our providers, for the most part, treat both urinary and sexual dysfunction, and we also have separate centers or divisions focused on cancer, although we do in our group routine cancer screening and diagnosis. As far as our APPs, they're also all over the various regions. So if anybody has any questions, I'm happy to answer them now, but please, for any questions you may want to reach out about later, particularly those of you who are tuning in to the recording from home, please feel free to email, text, or call me. My cell phone is there. For anybody interested in referring patients to our group, that's our general referral line for our Urology Institute. So any urology referrals for any type of problem can go through there. Our patients can contact that number to schedule as well. So once again, thank you so much for the opportunity to come and talk. and I'm happy to answer any questions either now or later on by email. Thanks.
Dr. Bajic, there is one question in the chat. It said, would you advise an estradiol level also on T therapy?
That is a great question. And let me see. Am I still sharing my screen?
No, your slide stopped about 4 slides ago.
Okay. Did it, let me just see here. I want to make sure that,
There, you're back up now.
okay, just in case anybody needs that context info. Okay, so let's talk a little bit about estradiol level. So early on in my practice, I used to check an estradiol level on everybody because that was just kind of what I was trained to do. And the thought is that if their estradiol level goes up too high while they're on testosterone replacement, that is bad because there's this kind of dogmatic belief that testosterone is good and estrogen is bad for men because estrogen is a female hormone. But in reality, both men and women rely on both testosterone and estrogens for various functions. For example, in men, estrogens are very important for orgasm. So I do monitor estradiol while on testosterone replacement, but I'll only treat it if it's pretty high and if they have some sort of breast symptoms. So breast enlargement or tenderness. But the two most common reasons that the estradiol would be elevated, number one, most common one I see is that the patient is on way too much testosterone. Either they're on too high of a dose of injectable testosterone, or they've been told that they also need to take other things in addition to the testosterone, like some men's health clinics put guys on HCG and all sorts of different stuff and various supplements to try to get their testosterone as high as possible. The goal of treating testosterone deficiency is not to put a guy in some superhuman range of testosterone. There's actually no real evidence to show that that is safe, most importantly, and really no evidence to say that it's any better than putting them in kind of the optimal range, which we consider to be about 600 to 800 nanograms per deciliter. And like I said, I usually check end cycle level. So if they're 600 at the end of their cycle, they're going to be well within the normal range through that whole week. So number one, most important thing is make sure you're not giving them too much. Monitor safety labs accordingly. There really shouldn't be a need for those other adjunctive things with the testosterone. The other group of men who get a high estradiol level is men who are obese, because in obese men, testosterone is converted to estrogen or estradiol in fat cells. So in some of those men, particularly those that develop breast symptoms, we might consider an estrogen blocker like an anastrozole. But men who have a borderline testosterone level and a very high estradiol level at baseline, who aren't even on testosterone, they might be a candidate for just an estrogen blocker by itself, because what that does is it prevents the testosterone from getting converted into the estrogens. So it can make the testosterone go up just enough for them to get the symptom benefit and then bring that estrogen down. I will also warn folks about using estrogen blockers too liberally, because if you bottom out somebody's estradiol too low, it can cause osteoporosis, which obviously is not good. So great question. Any others?
If anybody else has a question, please make sure to take yourself off mute.
Thank you.
All right, I think we're done. Thanks, Dr. Bajic, for joining us. We really appreciate it.
My pleasure. Thanks again, and always happy to come back again in the future.
All right, have a good night, everybody.
Good night.